with the invited lecture, and it will be followed by a panel discussion. The session will be chaired by Dr. Manoj Murekar. Dr. Murekar is the director of the National Institute of Epidemiology, Chennai, under the Indian Council of Medical Research. With over 30 years of research experience, his work focuses on infectious disease epidemiology, vaccine-preventable diseases, and disease surveillance. He directs the Field Epidemiology Training Program at the NIE. Dr. Murekar has previously worked at the Regional Medical Research Center, Port Blair, also of the Indian Council of Medical Research, and with the WHO Western Pacific Regional Office. He has authored over 250 peer-reviewed publications in national and international journals and serves as an associate editor for the Indian Journal of Medical Research. Dr. Murekar will chair the session, and along with Professor Ramabaru, I will moderate the session. Over to Dr. Murekar for the chair's address. Dr. Murekar, please.
Dr. Rajiv, I hope you can hear me.
Yes, very well.
Thank you very much, Professor Rajiv. At the outset, on behalf of the Center of Social Medicine and Community Health at JNU and ICMR National Institute of Epidemiology, I welcome all of you for the second webinar on epidemiology and social sciences. This center, the Center of Social Medicine and Community Health, was established in 1971 with the mandate of evolving the contours of discipline of social science as suited to Indian context, with all its diversity, and with special attention to vulnerable sections of the society. The experience of developing its theoretical base and curriculum for the various teaching and research programs offered by this center have served well over generations of students as well as faculty. This center and ICMR NIE have a long relationship, which was cemented by a formal agreement of cooperation, which was launched in 2022 by Dr. Soumya Swaminathan, the then Chief Scientist of WHO. Social epidemiology, eco-social epidemiology, and social determinants of health have brought the concepts of social science into epidemiological theory, methods, and practice. And this second webinar, comprising of an invited lecture by Professor Veena Das and panel discussion, will examine this complexly intertwined relationship. So I will now request Professor Rajiv Dasgupta to introduce our first speaker, Professor Veena Das. Over to you, Professor Rajiv.
Thank you, Dr. Murekar. Professor Veena Das, a very warm welcome on behalf of the Center of Social Medicine and Community Health, JNU, as well as the National Institute of Epidemiology, Indian Council of Medical Research. Professor Veena Das has very kindly agreed to deliver this invited lecture. Professor Veena Das's research and teaching bridge various traditions across anthropology, philosophy, and public health. She is an elected fellow of the American Academy of Arts and Sciences, Academy of Scientists of Developing Countries, and the British Academy, and a recipient of honorary doctorates at the University of Chicago, Edinburgh University, University of Bern, Switzerland, and Durham University, UK. She received the John Simon Guggenheim Fellowship in 2009, the Nassim Habib World Prize, University of Geneva in 2014, and the Sudhindra Chakraborty Award, University of Calcutta 2020. Currently, she is completing a book on anthropological knowledge and a co-edited book, The Challenge of Description. Over to Professor Veena Das. Once again, thank you very much. This is an invited lecture without any questions and answers. We will have the panel discussion following this. We will request you, one, to please keep your microphones on the silent mode. Two, to put questions to the panel in the chat box. The moderators will pick it up and discuss at the end. And those of you who would like to sign up for this webinar series, we would request you to put your email ID in the chat box. Thank you very much, Professor Veena Das. Welcome and over to you. You are on mute. You'll have to switch on.
Can you hear me now?
Yes, of course.
Okay, thank you. I want to start by thanking Professor Dasgupta and Professor Murhekar for chairing the session and for inviting me to this webinar and inviting me to share in some ways my thoughts on the questions about what is it that COVID-19 might have taught us about revising in some ways the certainties that one might have built over since 1832, that we in social sciences understand what epidemics are as biosocial formations and entities. I'm very honored to be speaking on the 50th anniversary of the School of the CHMS, and I want to say that the school has played a very, very pivotal role in focusing on questions of health, particularly with regard to vulnerable sections in a broader sense. When I was teaching at the Delhi School of Economics for about 30 years, it was a very important place in which one could really test one's ideas and learn about the new research and challenges that we were facing with regard to the questions of health and poverty. And of course, we had a lot of domination in some ways by questions of statistical methods and ways of thinking about health from the perspective of the poor. But I've never been particularly sanguine about the idea that somehow what we have is some kind of surety of how to go about understanding new epidemics. So what I'm going to present is not really any definitive lessons. I think what COVID-19 showed us was the range and the depth of our ignorance. And I'm going to try to say in what way does this ignorance certainly manifest itself in the challenges it posed to me and a whole team that we had assembled from China, Brazil, Chile, and the US to think collectively, and Korea to think collectively about what did it mean? What was COVID-19 to be seen as a kind of global epidemic which only had these small cultural variations, or could we say that in some ways the experience of the pandemic, if you were living in Korea or if you were living in China, was a completely different one from the experience in India? And further, in India itself, it wasn't particularly clear to me that we actually had the wherewithal to be able to understand what became a very big challenge, which was what was it to understand the cascading scales at which different kinds of relationships came to be articulated. So the four issues or scales at which relations get configurated that I will be looking at. First, there is the question really of looking at the pandemic through the models of transmission, especially the epi models, which became very dominant and We would see at Johns Hopkins, because of the fact that it took a very leading role in trying to get the prevalence and the disease transmission models that were being made. You were confronted with interactive maps and with graphs almost every day. And it became very habitual for people to try and see, to go on the net to see, what did the graph look like on that particular day. And so there's something very interesting that happened, which is how much data became part of at least certain ways of thinking for many people. The second was the fact that at this particular scale, I was very struck by the fact that the legal picture looked completely different. So there was the question really of the implementation, which in different phases in India, for example, initially there were really draconian legal measures. If you just look at the number of cases of infringements that were registered initially, these went into more than 60,000 cases were filed, 13,381 arrested for lockdown variations in Maharashtra alone. And although many of these cases were dismissed, it tended to show that in the initial stages, the implementation really of the measures, such as lockdown, were extremely draconian. And it's an interesting question to ask, how did change happen at that level? The other was the very large number of cases that were filed. I think that 600 that we filed. There were very dramatic cases. I'm sorry, I think there's some interference, but yeah, okay. So there were very important cases, particularly the first cases in which the Attorney General Tarun Mehta presented the report on migrant workers.
Muted.
Professor Das, you are muted.
Yeah, I'm sorry, someone unmuted me, so I don't know. Sorry
We can hear you now. Thank you.
You can hear me? Okay, great. So I was saying that ranging from the very consequential cases on the migrant labor, in which the Supreme Court initially took a very modest stance to say that these were policy issues and that it did not really have a jurisdiction to intervene, to the dramatic, very long letter filed by major attorneys, starting with Chidambaram, including human rights lawyers like Indra Jaisingh and many others. And this letter pointed out that this was not purely a question of policy. It was a question of the Supreme Court inviting them to take a more active role and saying that what was at stake was really the citizens' rights because of the fact that migrant labor situation had actually led to thousands of lives in precarity. And also because of the fact that it was the occasion used by the Attorney General then to present what I can only say were a series of lies. For example, to say that there were no migrants, that migrants were not for railway, that they were being provided medical attention. If you looked at Tarun Mehta's report, Tushar Mehta's report, it would really look like, I mean, I work in the slums in Delhi have been working there from 1999, looking at questions of health and disease. And if you looked at that particular report, I mean, there's not a single neighborhood in among the low-income families that we have been studying, and we've been studying 6 neighborhoods, in which these kinds of facilities are actually available. I think the letter pointed out that the Supreme Court had an obligation to not simply accept these kinds of findings, but to present the with more truthful reports. And in this, I think we also began to see the tremendous role of social activism, for example, the formation of various NGOs on the rights of migrant workers, the kind of evidence that they produced. For example, it was very interesting to see how they would collect things like the tickets, the railway tickets, and how much they had paid for the railway tickets, anything from 400 rupees to 600 rupees, in order to get to their places of origin. So you had, on the one hand, the draconian kind of measures, and then over a period of time, the actual learning that was happening in the context of the establishment of some kinds of legal rights. And I think that it led to very interesting policy changes on for example, the supply of periodic rations, which were very central for those at least who were in their residences. So that what you got then from very draconian measures of simply implementing these recommendations of total lockdowns was in some ways some concern to saying that under these kinds of lockdowns, what kind of provisions could the government actually provide? The level, if we look at these cascading levels, the other very important things were the actual planning, for example, of what kind of preparedness and emergency measures could be taken. And here, of course, we've been matching things like the prevalence rates day to day at that time, and the beds which were assigned for COVID patients, and the number of beds that were actually occupied. And you see a huge variation. For example, during the Delta period, you had a huge rate of occupancy, and you also had the preparedness in the sense of setting up large field hospitals and then finding that no patients turn up. But meanwhile, I think what went under the radar was the fact that people were paying no attention to comorbidities. And therefore, we know that TB notifications declined considerably. I mean, it's a scandal that TB was made a notifiable disease only in 2012. But clearly the fact that a very large number of TB patients were actually being treated in the private sector, not really by fancy hospitals, but by the Ayush, by the so-called untrained providers whose practices, as we have shown, were not markedly different from the practices of the MBBS doctors who were practicing in poor neighborhoods. So we didn't get a composite picture of really what was the disease scenario. I'm sorry. Was there someone asking something?
No, we would request all participants to be on mute, please. This is very distracting and upsetting for the speaker. Request everyone to be on mute, please. Ma'am, over to you, please.
All right, thank you. So the second was the scene of comorbidity at that particular level. And the third point that I would want to bring up is that the comorbidity question, of course, brings up the question of health systems and not simply preparedness questions for an epidemic and how it was implemented, but in what kind of way the fault lines in the health system also had an impact upon the particular course of the epidemic and and the larger mortality. I think now people are recognizing that instead of counting COVID-19 deaths as a separate category. What one should be comparing between the different years is the excess mortality, regardless of the causes. And regardless of the causes, because these were, as I will show, very interlinked with the policy measures which had been taken for COVID-19. The last point about the scale that I want to say is that there are two black boxes that on which social science actually does not have very good theories. One is the role of the street bureaucrats. I think that what COVID-19 showed us was the extremely important role that the street bureaucrats played. So this is everything ranging from ASHA workers to, to the A&Ms, to the ground level health workers, ordinary policemen, lower bureaucrats who were in charge sometimes and had to act on the spur of the moment of organizing transport for people. And much of what their work was tends to disappear from the record, because although the theorization of street level bureaucrats has been done in public administration, it's generally, there is a kind of obsession to say that if you give too much power to street bureaucrats, they're likely to act arbitrarily. So, you had, of course, very, very clear measures of supervision. But it's really the street level workers, I think, who were the heroes of the epidemic. And we have very, very little precise information on what kind of work was entailed. We know in general that, let's say, every ASHA worker or the Anganwadi workers were given 10 households or 20 households under their supervision, and had to survey these households once a week and then report to their supervisors. We also know that in the initial stages, they were given no protective equipment, thereby creating a lot of tension about what kind of exposure were they being subjected to. We also know sometimes that very splash decisions which were taken, for example, the migrants who were, there was a period when the states were not willing to allow movement of migrants. So West Bengal, for example, had resisted first receiving migrants from Maharashtra. And then when they opened that, the street bureaucrats or the lower-level railway workers who acted were really to try and stop the train halting at every station, so people wouldn't just get dispersed all over, but that they were brought to, the train stopped only at one station midway, and then at Hooghly station, they were all gathered and tested for COVID. These things go unreported in the final analysis, but I think that this is a blind spot in some ways, where we are so obsessed with the discretionary power of the street bureaucrats that we fail to see that much of the management of epidemics actually falls upon the lower level street bureaucrats. And research now has shown that street bureaucrats do not, by and large, take arbitrary decisions. So there is some very interesting work in AI, which tends to compare the decision models used with the help of AI agents and the AI algorithms, and the actual decisions made on homeless workers, homelessness in the US, for example, which shows that the decision made by these case workers were by no means arbitrary in terms of whether, who was to be prioritized, whether they were to be given, placed in shelters, or whether they were to be placed in temporary households. There were serious ethical and deliberative processes that were at work. So this is the other kind of lacuna, I think. And the other very big lacuna is really that, despite the fact that anthropologists and sociologists have worked on the household and on the family now for, for at least quite seriously since the 1930s. We actually tend to treat the household as some kind of a black box. In the economic model, there is an input that goes into the household, and we can see the outputs that come in. So we can see that if we educate mothers, the infant mortality goes down. But we don't know the processes by which this happens. And so we also do not know, despite the, I think, very inspiring work that Amartya Sen opened up on this, on thinking about the intra-household inequalities. We actually do not know what kind of triage was actually exercised during COVID-19, which related to decision-making within the household. And I'll give some, we know that two very important factors which were implicated over here. One was the actual kinship and social networks that were available to a household. And second was the actual periodic help that came in, whether from the state in the form of cash that was placed in women's accounts, or in the form of rations, but also the fact that relatives and neighbors actually caught difficult moments. For example, a household where the mother had got COVID-19, the neighbors would supply food, and the role of organizations such as the Gurdwaras in providing food. I think that why this was very important was that if you look at this through recall, for example, if I now interview people and say, what was it that you faced mostly in COVID-19? People will come up with pretty dramatic events that happened, right, in their household or in their neighborhood. But because in this period we did weekly interviews with these households for a period of 16 weeks, we could see that it was actually what in psychology is now called the small hassles. That is to say, the fact that you went to the ration store, you waited for 3 hours and the ration did not come. Or the fact that you had actually put money with the committee with a neighbor, and when you went to claim that money because there was an emergency, you were not able to get it. The fact that you went, your daughter fell down and you went to the hospital because you were scared, because she had a terrible fall, but you couldn't find admission in any hospital. It was these things at that time that were constantly recalled in the week-to-week surveys. But when we now look at it, what are recalled are only very dramatic events. So we actually don't have a theory of household in continuous time. We have a theory of household in discrete times. But I think that this COVID-19 showed us that because the temporality of provisions for the poor is very different from somebody who gets a monthly secure income. We really found it very important to build that temporality into our understanding of how COVID-19 was absorbed in the household, not as the same kind of crisis as it was in the global theories of COVID-19, and not even in the national policy statements, but there was some understanding of the fact that the temporality of the poor households in terms of provisioning is very different from the temporality of the better households. So Rajiv, will you let me know how much time I have?
Another 10 minutes.
Okay. Okay, so I'm going to rush through couple of other important points. The first that I want to say is that, so what are we did learn some lessons, but these were really lessons about what we what we could not do. And I don't say that this I think that it's we're too quick to kind of put blame on people. But what we need is a kind of discourse in which we understand that the COVID-19 was a huge challenge to every discipline. Nevertheless, I think I do want to point out that in the classic epi model, you do have, you have a model where sick people infect others, some recover, others die, and those who recover can't be infected again. So as the epidemic rises, when there are many people who have not yet fallen sick and then falls, as more people gain immunity, you get the herd model. What I think the EPIC models really missed was the fact that there were other data requirements, which, because of the fact that they spoke with such certainty about the rates of biological transmission, they could not actually, I think they could not build what was the nature of human interactions, what was the nature of the social interactions. And I give you just one example. One is that, because India doesn't have contact surveys, and because we don't have contact surveys, we actually do not. What happened in some of the models was the extrapolation from Europe to the age and household structure in India. And although it was recognized that because of the age composition of the Indian population, you had much larger, younger population. Nevertheless, it seems to me that what is very interesting is that surveys that have been done have shown that the number of contacts that people have on the basis of these diary studies of contacts that have been kept can range from 3,000 to 4,000 per person. Now, this is a huge variation. And it seems to me that models built on the assumption that the contract distribution, say in Rajasthani villages, is identical to that in the Polish villages, obviously leads to tremendous distortions in the epi models. So one very important part is that, that there was a deep problem of the fact that there was no anticipation of the fact that where you have large number of migrant population who actually live day to day, and if you're going to have a total lockdown, then this is the population which will move. And if this population moves, you would actually get the spread of the virus. And I'm not saying that they could have anticipated this straight away, but it does seem to me that we need to now identify what kind of regular data collection needs to be done, which looks exotic. Why should we be doing contact informations? We did things like how many people did you call on your cell phone? Or we asked regularly weekly informations on, who did you visit? Did anybody come to visit you? We did we collected regular information on what happened when they could not go on their site of work because of the total lockdown. What accommodations did employers make? And I think that what we need is regular data on this so that we're not caught by surprise, and so that the epidemiologists are given a fair chance to be able to build this data into their epi models. The other, I think, very important, interesting thing that happened, on which, as I said, we have a huge number of legal cases that we are analyzing. And what it showed on the one hand was the robustness of the Indian activist scene, in the sense that people just did not, there were, of course, some lawyers who regularly filed PIL petitions, right? But it was very, very important that these issues were brought before the courts. And it seems to me that, again, that we need to be able to think that preparedness is not only doing biological models, but really doing much more work on the on households and on the neighborhoods and on the normal lines of fault lines and lines of conflict. So I give you two examples to make this clearer through actual examples of what was happening to people. So here is the kind of thing that I have in mind. Most deaths that happened in the households that we studied did not happen because of COVID-19, except for one death. These were mostly older people, and these deaths happened either because they were suffering from TB, and then normal processes of getting TB medication failed, either because there was no one in the household who could accompany them to the place, or because when they went to the hospital, they were asked to get, it was a huge thing to go and first get a certificate, first get a COVID test done, which seems fine on paper, but for a poor person who's taking off for that day to be able to go and get TB medications for his father, it was really a very, very hard. It was very hard to decide whether to forego the income or to get the medicine. There were other ways in which these in one way I would say that it became clear over a period of time that because most private sector doctors either stopped practicing, or from our interviews, which would be like, I went to the doctor, I went to my normal doctor, and he didn't see me. He just told me he just kept me outside, and he told me to go to such and such hospital. I went to that hospital, and they said, no, now we only take COVID patients. And so they sent me to another hospital. I went to that hospital, and there they said this, and so on, right? And so the deaths that happened, and in fact, the deterioration was often because of this comorbidity, and that was often because the comorbidity had not really figured in the policy decisions that had been taken. In the short presentation that I have over here, what I want to argue then is that we need to think about not that the epidemic had a boundary, that it started on such and such time and then it ended at such and such time, but to really think about preparedness for these kinds of conditions by equally paying attention to the fact that there's enormous failures in some ways of the fact that Arunima Pathi and his colleagues, for example, on the basis of pharmaceutical sales, calculated how many people were being actually treated for TB, and they found that the number was 3 to 4 times higher than what the WHO predicts, because the WHO predictions were based upon projections made by experts. But the WHO itself admitted that all the data that we have on numbers is indirect estimates, right? And of course, now we have the new TB survey, and hopefully more reliable data will come in. But there's huge number of patients of TB or patients of diabetes who are not just, TB is known to be a disease of the poor, but things like diabetes are often assumed to be something which happens only to the rich. But what we found was that some of the deaths and some of the grievous illnesses happen because people fail to get their normal anti-diabetic medications. So it seems to me that what I'm pleading for is an approach in which our attention to the everyday forms of medical care are less ideological and more related to how the poor actually get care, and to try and see in what kind of way, what kind of preparedness do we need in order to be having the kind of database that would allow those who those who model these epidemics to have much better data and to recognize that policy making under these conditions is always policy making under huge uncertainties, and therefore to have the kind of flexibility which would take the requirements of different people into account. It was not really for the poor. It was not your life or your money. It was both your life and your money, which was really at stake. And so thank you very much for listening to me and for allowing me to share what the problems are, even as we are in the middle of analyzing a pretty large data set from these 5 different countries, and to be showing that ignorance is not a bad thing to acknowledge. I think we don't have to always speak with absolute certainty when we don't have that certainty. Thank you very much.
Thank you very much, Professor Das, for providing reflections of from COVID-19. Since this is an invited talk, we are not going to take questions on that. So moving the agenda forward, may I request Dr. Rajiv to introduce the panelists. Over to you, Rajiv.
Professor Veena Das, thank you very much once again on behalf of the organizers. We now move on to the panel discussion, and we also have a set of very distinguished panelists. I'll introduce the 3 panelists and then hand over to Professor Ramabaru for the moderation. First, to introduce Professor Virginius Kaka. He is a visiting professor at the Institute for Human Development, New Delhi. Before joining IHD, he was a professor of sociology at the Delhi School of Economics, Tata Institute of Social Sciences, the Guwahati campus, and Tezpur Central University. He has authored, co-authored, and co-edited several books and published articles in national and international academic journals and edited volumes. He has been a member of the National Advisory Council and the chairman of the high-level committee to study the socioeconomic, health, and educational status of tribal communities of India, constituted by the Government of India in 2013. Welcome, Professor Kaka. We then have Professor Rajesh Kumar. He is currently Director, Health Equity Action Learnings Foundation, and Associate Editor, Journal of Epidemiology and Community Health, and a Senior Consultant in the Journal of Medical Research. He has worked earlier as Dean Academic and Head Department of Community Medicine and School of Public Health at the Postgraduate Institute of Medical Education and Research, Chandigarh, and also been the Honorary Professor, Department of Communicable Diseases, London School of Hygiene and Tropical Medicine. He obtained MD in Social and Preventive Medicine from Medical College Rohtak. He is an MSc in Epidemiology from the London School of Hygiene and Tropical Medicine and Fellow of the National Academy of Medical Sciences. Dr. Rajesh Kumar, a special welcome. It's late night. You are joining from Sydney, and thank you very much to be part of this at a time which is convenient for the most in India. Thank you very much. Now we welcome Dr. Tarun Bhatnagar. Dr. Tarun Bhatnagar is MD Preventive and Social Medicine from Banaras Hindu University, Varanasi, PhD in Epidemiology from the University of California, Los Angeles, a postgraduate diploma in bioethics from the Indira Gandhi National Open University, and is currently in the position of Scientist F and Head ICMR School of Public Health at the ICMR in IE Chennai. He also serves as the Scientific Director India of ICMR NIAID International Center of Excellence in Research, Chennai. His research interests include causality, HIV epidemiology, epidemiology of emerging and infectious diseases such as Nipah virus, Zika virus, COVID-19, analytical observational studies, health systems research and evaluation and assessment of public health strategies and programs. Dr. Bhatnagar has authored 90+ research publications in scientific journals and has a book on health research and 4 book chapters. Once again, a very distinguished panel. I hand over to Professor Ramabaru to moderate the panel discussion. Once again, a request to everyone to kindly keep your microphones on mute and put your questions on the chat box. Thank you. Professor Baru, over to you.
Thank you very much. It's indeed an honor and a pleasure to moderate this panel. I also want to say that the people who are on this panel are people whom we've had continuous dialogue with in various forums on this issue of social sciences and epidemiology. And I think that we'll begin this panel. We'll have 2 rounds. And I have very specific questions, which I will ask each of you, and then we will have the second round where all of you can reflect on some of the other questions. I'll begin with Dr. Rajesh Kumar. To what extent has epidemiology engaged with the social sciences? What are the gaps and challenges for furthering this engagement?
Yeah, thank you for giving me this opportunity. I think this is a very relevant question. Traditionally, epidemiology, the domain has been to study distribution of diseases, and the focus had been to identify the causes and to understand the transmission dynamics and risk factors, primarily to prevent or control. And in this process, epidemiology has built up a good collaboration with mathematicians and statisticians and went into that direction of quantitative studies. And it has occupied now a place as a central theme in medical sciences. I mean, once people used to be a bit skeptical that epidemiology is studying the associations and does not go into the mechanisms why and how these causes cause illness. But now, at least in medical science, it occupies an important place. As far as social sciences is concerned, epidemiologists have been examining the role of social and economic factors like income, education, occupation, and more so now lately, lifestyle influences on disease occurrence. And thus, a collaboration with social scientists, especially psychologists, developed in this process, and even a subdiscipline of behavioral epidemiology came into existence. And now, in the last 3 or 4 decades, there has been now some engagement with social sciences, especially after 1990s, and the importance of social determinants of health and other societal influences in disease spread has been recognized now. And now social epidemiology is recognized as a subdiscipline of epidemiology, and which, the focus of social epidemiology is now on studying inequities, impact of socio-economic policies, cultural practices, even impact of policies on public health. So there has been now a growing collaboration of epidemiology and social sciences, but lots of challenges remain. As you asked, what are the gaps and challenges? To my mind, one of the important gap is this interdisciplinary communication. The social scientists, they come with their own background. There is a lot of methodology and terminology, epistemology, which differs. The approaches differ between the 2 disciplines. And so, which hinders, the effective communication, understanding the point of view from different angles. So one needs to build this dialogue between disciplines and mutual understanding. This is one gap. Second gap I see is like in social sciences, there is use of this qualitative methodologies, whereas epidemiology is more rooted in quantitative methods. So, how these two approaches can be integrated in having a holistic understanding of the problem. So we need some understanding, some comprehensive understanding, how to use these methodologies together. And we need to do that more so because the health problems are so complex, as we understood during the COVID pandemic. The things and social problems are so complex that we need to integrate and understand from various points of view, social, environmental, biological, from every point of view, so as to have a better understanding. And we also sometimes fail to understand why output of research is not going into policy, why research is not moving to policy. So here is again social scientists can play an important role in giving an understanding how policies are formulated and what one needs to do to achieve that. Another challenge I find is that the disciplines, they work in silos. You see, like for research, we have Indian Council of Medical Research, and there is another council, Indian Council of Social Science Research. You see, so the collaboration is also needed at that level, so that scientists with different backgrounds, they come together to study, a health issue. So that kind of collaboration between the structures are such that, the collaborations are impeded. And similar is the case, most of the epidemiologists, they work in medical institutions, whereas social scientists, they are based in universities. So that kind of inter-institutional collaborations is another issue. And last of all, I would say that to have a lasting impact and to have a fruitful collaboration between social sciences and epidemiology, we need to change our training programs and education programs. Like we need to have, in our training programs, both, a study of epidemiology along with social sciences, so that we can groom a group of researchers who understand both sides, and that can benefit, better understanding of the problems and finding better solutions. So I think to my mind, these are the gaps. And it's a lot of challenge in bringing social sciences and epidemiology together, but I think there is a need for that. So these are my initial thoughts. Thank you.
Thank you very much. Now I go across to Dr. Tarun Bhatnagar. And you've been a faculty teaching the MPH program at NIE for several years. So what do you think as a faculty, what are the skills that are needed for much better integration of social sciences and epidemiology? Where do you see resistances to this also?
Thank you, Rama, and thank you for having me on this panel. Of course, along with the Center for Social Medicine, Community Health, and NIE, the CSMCH is celebrating its 50th year, and in fact, they just realized that NIE is celebrating its 25 years, so we are sort of halfway there. But it's good to be together, and I guess that is the philosophy that we have over the years adapted to in terms of teaching the public health course here at the ICMR School of Public Health for the Masters of Public Health course. And and this has been an evolving process over the years, where when we started out with the curriculum that was in 2007, almost that's many years ago, where the curriculum was essentially in terms of teaching social and behavioral sciences, was a very heavy curriculum on theory and on behavioral sciences and so forth, taught by very accomplished faculty, of course, in their area, but again, with this certain aloofness to the quantitative world and the epidemiological approaches, as if I may put it that way. And then we found that there was always a gap that existed in terms of understanding of how social sciences and epidemiology could actually go hand in hand together. Over the years, and also, so I was just thinking out of what was needed and what did we do. And I thought of, okay, I think it starts with the attitude of the curriculum makers and the faculty and the people who teach, in terms of their openness to having different faculties come together. Where faculties, I mean the faculties of studies and subjects. Here we're talking of social sciences and epidemiology, the quantitative, qualitative world, to come together to try and understand the problem as well as to sort of solve an issue. Now, how that happens would have to happen through, I think, again, another A that plays a big important role here, I feel, is the aptitude of the faculty itself. What we've also realized over the actually more than 15 years of teaching, is the faculty who teach EPI and the faculty who teach social sciences, what is their aptitude? Have they themselves had some training and some exposure to each other subjects? And we've realized over time that when there are people who, if there's epidemiologists who have had exposures and not just exposures, but some level of trainings, at least in the social science discipline, they tend to be more, how do I put it, more accommodative, more empathetic to bringing these two sort of paradigms together in terms of the teaching purposes. And so again, so that there needs to be that aptitude. And similarly, I would think that the social scientists who come into the picture, also those of who have exposure and who have the ability to accommodate and to think about bringing the quantitative nature of the problem into the picture, also do, I would feel, much better in terms of actually communicating the sort of the ideas that come through the paradigm of social sciences. And then I guess finally also need to understand who the audience is for this teaching purposes. Who are we talking to? For example, if I take the ICMA School of Public Health here, our audience is essentially medical doctors who come in, and so they come from a medical frame of mind, and more quantitative definitely than qualitative. And then how to sort of help them bridge that gap between epidemiology and social sciences was a challenge and remains a challenge, but then we're sort of taking steps towards making sure that the teaching is action oriented. There is so we have the EPI course, and then that is followed by the social sciences courses, and we try to bridge it through people who have taught epidemiology to actually also show how that there exists really a meeting point of the two sciences, and it is not sort of two sort of disciplines in silos talking different languages. So again, finally, trying to talk the same language, but trying to make them understand it to the right audience. So I think, yeah, I'll stop there with my initial thoughts. Thank you.
Thank you very much, Tarun. Professor Kaka, you've been a teacher and a researcher in sociology. And so I'm going to ask you, as a social scientist, how do you see this engagement with epidemiology? Where do you see, is there a hierarchy in the power relationship between epidemiology and social sciences? I think Veena's lecture alluded to it. So I just want you to reflect on that.
Thank you very much for the invitation. I'm not a person from public health or even health issues. Let's say I have been engaged particularly with the study of tribals and mostly in the context of development. And in the process, I've looked at educations, poverty, health, and so on and so forth. And I find that, in social sciences, you find that each discipline have developed their own set of terminologies and concepts. Let's say in sociology and anthropology, probably there is much more common. Economics may have, again, very different kind of some concept. But nevertheless, there is some degree of commonality among different social science disciplines where they really accept some of the key concepts. One is, of course, what is called the social exclusion. And, it is an interdisciplinary concept widely used in understanding, let's say, poverty, the health issues, and so on and so forth. And I find that when you talk about social exclusion, is primarily a sort of a denial of things that are valued in a society. And if you look at the root of it, is social inequality. And therefore, social inequality becomes really very, very important in order to understand any sort of deprivation that really one really experiences, either let's say in the context of income or in the context of power or in the context of health, disease, and health status, and so on and so forth. Now, when we talk of social inequality, it takes varied forms. It could be a caste, it could be a class, it could be racism, it could be ethnicity, it could be subnational identity, it could be gender. And therefore, you find that in this kind of a context, you find that the health status or disease to great extent is patterned or is revolving around the kind of deprivations, the kind of social inequality that really exists in a society. So that's one point. And and this social inequality, if you're told you find that is a context of health, for example, if you find that infant mortality or child mortality is very high among the tribal communities, then you find that the highness, the difference is not so much if you really compare it with the Dalits or other OBCs and so on. But the moment you come to the under 5 mortality, you find that there's a phenomenal increase in the number of tribal children really having mortality. So what is it is under 5? It basically means that there is, by the time they move to 5, there is a aspects of poverty, this aspect of deprivations, and that in fact has a very strong bearing on the health status of the community. Now, so this the inequality that we really find, which is related or linked with the health, you find that it is also linked with the economic status, whether you talk of the nature of employment, whether you talk of income, and therefore, as I said, people poverty. You take educations, you find large chunk of people are illiterate or people who have just got primary educations or middle educations. Or you find that you take the politics, and you find again in politics, you find that probably you find that people who are the margin society don't have a space to make decisions in the institutions if it really matters. So you can see kind of inequality which is there in one sphere actually goes around different axes, and it becomes a sort of intersectionality where you find reinforcing each other, and therefore you find something happening in the economic sphere, something happening in the political sphere, or something happening in the social sphere actually is reinforcing the kind of problems that you find in this, let's say, in the context of health. So these are some of the issues that we really find. And inequality, I think we have to understand not something given, static. I think inequality is being reproduced. There's constantly being reproduced. And you find different kinds of different forms, what is called, the forms continues, but then the intensity and degree really goes on. And I think this, I think, is very important, particularly if you really take a tribal community. Between 1980-81 and 1941, tribal fertility rate was much higher than even the Hindu populations. And whereas Hindu population declined between 1881 and 1941, the tribal population really increased. And that was largely, they say, because of high birth rate and low mortality rate. But then you look at today, then you find that it is just the reverse. You find that, well, there maybe fertility rate is there, but mortality is very, very high. And therefore, you find that how do you really explain this? Because it's precisely because of the historical process of appropriations of resources, the impoverizations, if kind of inequality that's really come about. And therefore, one has to really look at, even in terms of creating inequality in terms of historicides, it's not something static, but you can reproduce, and you find constantly, you find the context of caste, like Dalits or Adivasis, you find that inequality is in fact further being reinforced. And therefore, that seems to be one of the important reasons as to why the health status, and you find that the disease seems to be much more rampant among the people on the margin than the people who are, let's say, on a better living standard or better income and so on and so forth. Thank you.
Thank you. We now go on to round two. I begin with Tarun. Mainstream public health still tends to focus on behavioral determinants at the individual level. What do you see as the limitations for this understanding?
All right. I think the word itself, when we think of behavioral determinants, we know that behaviors are influenced not just by the individual's own characteristics, but also by the environment in which the individual stays, plays, works, grows up, etc. So when we look at it from just an individual point of view, we tend to be probably ignoring sort of the environment around that individual, which is shaping all of these behaviors, and the behaviors of other people, behaviors of the systems, the sort of macro level determinants in terms of either the political determinants or the environment per se in terms of air, water, place such as that. And so we would tend to sort of miss out sort of the intersections that would happen. And then accordingly, I think what we would miss out is what would be the real interventions to be put into place to take into account, to address the individual's behaviors, which have to take into picture the sort of aggregate group behaviors, the group dynamics around those individuals.
Thank you. Over to you, Dr. Kaka.
I think, understanding health just on individual behavior is, I think, too delimiting. I think any social scientist probably will think that this is something which is really oversimplifications, because an individual is actually in a way part of a family, is a part of, let's say, a larger caste or tribe, a larger subnational identity, someone living in an urban area, someone living in a rural area, someone really, let's say, living, making livelihood on forests, someone in agriculture, someone in plantations, someone on wage labor. So you find that there is a sort of an individual who is actually interconnected with many things. And you find that the social or the environmental and ecological aspects do determine to a certain extent the questions of health status and the disease. And therefore, I think I find the looking at health primarily on individual behavior is something very problematic, and therefore I think it's important for us to expand it as to what is the reason as to why this has not really happened, why the social science component in understanding in health or disease is so weak. Probably it is to do with the way in which I think the, let's say, health educations or public health as really being pursued in the country. I think it has already been referred to. How much of social science components are there in medical education? So I think those are issues, and that I think I'll take a little later when we talk about.
You open the door, close it also.
Over to you, Dr. Rajesh Kumar.
Yeah, I think primarily in the medical science, the focus is individual. And when we think of cause and effect, you see, most of the time, this is, the action to be taken. We always think that individual will take the action. And the individual in a way is at fault, That's why disease occurred. Did not eat well, did not wash his hands, or, so many things. So this is ingrained in the medical profession right from the beginning. I don't think after eighth class they ever study any social science subject. You see, they are always in this physics, chemistry, and biology, etc. So these things, this biomedical approach is ingrained, This is like their second nature. So for everything, this is the individual responsible. So, and they would like to give education, educate this individual, you see. And so it is kind of, in a way, it also, becomes very easy for them because they are not responsible for it. The person sitting in front of them is responsible. So he or she has to improve himself or herself. Even, society is not responsible. Because you see, as Dr. Khaka mentioned, that it's a very complex problem, And even in epidemiology, we say web of causation. There is a web of causation, multifactorial causation. But we always try to see that in this multifactorial causation, we always see what is the chain. And in the chain of causation, try to break it, wherever you can break it. So it becomes very easy to advise the individual. It becomes very difficult to advise the government, to advise the society, to change the social system. So they think that this is beyond them. And public health in this country is primarily run by medical doctors. And that's why you see always this approach of individual behaviors. It is very safe for the government also, you see, because government is not responsible. People are responsible. So I think that's why this is going on. But as gradually we are understanding that behaviors are not in the control of individual. They are governed by so many factors outside, social factors, cultural factors. So problem is much complex and we need to find solutions for this at the social level. So I think the understanding among those who are running public health has to change for changing these policies. Thank you.
Thank you. I'm going to, since this question has come up, I'm going to ask the three of you, where are the spaces to even influence one medical education, the public health education? Because today you see a plethora of private institutions coming up for MPH programs. Where do we find possibilities to intervene and to bring social sciences and epidemiology together in public health? I'll begin with Dr. Khaka.
Well, as I said that I'm not very sure about it, but I think when we think about, let's say, public health and, taking it beyond individual behavior and try to relate with social sciences, maybe one of the models that we can think of Indian Institute of Social in technologies, in essentially technology institutes, but you find that let's say social science components, whether it's a philosophy or psychology or sociology or history, are really become an important component. How much they get about it is different matter, but I think there is a sort of what called drawing them to attention to the fact that there's a social dimensions, there's a social sphere, and I think we do give some input, so that there's a possibility for medical college or medical sciences, to have that kind of a pattern in teaching that one kind of things. Secondly, I feel that let's say some of the we are in university, we are too much disciplinary bound, but there are some where I think there's openness. For example, if you take education, I think educations you find that people from science, the chemistry, the physics, the philosophy, the sociology, psychology, and therefore there is some sort of an interdisciplinary. I always felt that how is it that the health, such an important issue, couldn't really have that kind of exchange of people coming from the different disciplines and really build something, let's say, on health issues, larger canvas is that. So that is one. That is the second thing that I would like to see. Third, I think it is important for us to build a sort of interdisciplinary issues. For example, I think most of the universities that came in the 1990s onward, they were mostly thematic based, development studies, this is gender issues, there were environmental studies, and you find that it was not much discipline. That is a different matter. But nevertheless, there were universities that were really coming up, which were really based, thematic based. But I have not really seen any new universities where you find, or not heard of it, where you find that the health has been on the important theme around which you say curriculum has really been built. For example, I think the kind of curriculum that you run, and let's say social medicines and community health, or this kind of an institutes in many of the universities that's not really available. Maybe Tata Institute is another place where there is this kind of an opportunity. So what really I feel is that in order to bring social science components in the health, I think there's a need of imagining ourselves, particularly as to what we really do to introduce the social science component in public health, in medical educations, in let's say universities, let's say in other kinds of institutions. Issue like health is cannot really be understood by one single discipline. It is interdisciplinary. And I think there's a need for everyone to come. And often you find that even when you are interdisciplinary, sometimes we think in silos. Oh, I'm a sociologist, I'm an anthropologist, I'm an economist. And there is hardly any kind of an exchange. I think for the good of the public health, I think it's important for us, even as a social scientist, to come really together and see as to how we can really take the issues really forward and try to bring maybe perspectives, maybe concepts, which can really be much more meaningful in understanding, let's say, the health status or disease from the social science perspective. Thank you.
Thank you, Dr. Rajesh.
Yeah, I think I endorse that. Actually, Professor Kaka has outlined the way forward. I think we have to move, public health traditionally, we were a colony. And even now, a lot of colonial thoughts go on. Like we inherited this public health from England, and over there, this was within the domain of medical doctors, and so that tradition is going on. It is very recently, in the last 10 or 15 years, that schools of public health, master of public health programs have started in India. And most of these public health programs, they recruit students, they admit students from various disciplines. That is a good thing, not only from science, but they take students from other disciplines also. And particularly now in your university, like in JNU, you take perhaps students from different backgrounds. And this Mumbai also now has this MPH, social epidemiology, health systems, financing, different types of MPH. So these are the beginnings, I would say. But perhaps now we should move these programs into university system, where you can avail the opportunity of interaction with various social science disciplines, and then there can be more interaction. We should we should have an integrated public health program in the universities, and not only at the postgraduate level, but maybe start with the undergraduate level. Why not? In the undergraduate courses also, there are different streams, and some students can right from the beginning can take up some courses of public health. You see, whether the concept of a major stream and a minor stream, something of that kind, so that health becomes one of the interdisciplinary, really an interdisciplinary endeavor in the institutions. I think that is required actually if we want to see any progress in future. And this another issue is of terminology. You see, social scientists, when they talk, if we listen to their talks, half of the things we don't understand. When they say social determinants, so we don't understand what is the meaning of social determinants. We understand economic, we understand education, occupation, but it social structures, they talk about social structures. What are these social structures? You see, so unless, right from the undergraduate, people have that kind of a milieu where they understand different disciplines and terminologies, this coming together just artificially won't solve the problem, but we have to make that kind of a beginning. Thank you.
Thank you. And Tarun?
Yep. Several thoughts are floating. So let me start off with, now that in today's times we are talking of and we're using the word public health, which if I go back to my to the days when I was doing my MD in preventive and social medicine, public health was something. There was an Oxford textbook of public health that we heard that word of public health, but there was no discussion around this concept of public health. And that has changed over time. So preventive social medicine, I'm just talking from a medical curriculum perspective. Preventive and social medicine became over time community medicine. So there was some sense of the society and the social aspects that probably came into picture when we sort of, with the change in terminology. But I guess things were still heavier on the side of the word medicine. So we couldn't get away from the medicine. And then more recently, we have public health. We have schools of public health. We have, again, even in schools, again, one very interesting phenomenon that I'm observing is in large institutions which have been teaching community medicine. So there's still community medicine, and then there's a separate school of public health or a department of public health and a department of community medicine. So instead of trying to come together, we're still sort of trying to keep these things apart. Again, we'll have to, of course, think of who's making these kinds of decisions and why that is happening. Some of it is medical oriented, a lot of it is medicine oriented, and then again also sort of some kind of hierarchy that still exists in terms of which is a hard science and a soft science, and a hard skill and a soft skill. Those differences, I think, need to be sort of, those lines need to be blurred in terms of having solution oriented approach rather than like a discipline oriented approach. What is it that's going to help me solve this problem of health for this particular community, or for even within hospitals? There are social issues, there are cultural issues that operate even within hospitals for that matter, let alone just talking of communities and societies. So that is one aspect. The second aspect, I feel, going forward and seeing the change. So now you see a lot of professionals, again talking medical professionals who are trained as MBBS doctors or MDs, who have taken up upon themselves to learn, to educate, if I may use the word, to educate themselves in the social sciences. And you see that those are the kind of people who are sort of, who more accommodative, more empathetic to, or more sort of solution oriented to what should be the actual solution rather than being bound to a discipline. So I think going forward, the teaching and training of people, again, since we're talking of health and a lot of it is on the sort of shoulders of medical doctors, but then we need to be sort of pushing for a more interdisciplinary teaching and sort of celebrating interdisciplinariness rather than keeping people aloof and having that sort of discipline based hierarchy, if I may say so. Of course, there are issues about curriculum, how those are designed, the issues about the intake of students. But I would still feel, I think, those having this training again, because I feel what you teach is what goes ahead, and those people, they learn and they would teach the same thing to others. So we need to also change our ways on the which way we teach our students, and sort of which is big, which has to be more interdisciplinary and basically talking with different disciplines. So we've got economists, we've got humanity, we've got behavioral scientists, anthropologists, epidemiologists, infectious disease specialists, all coming together, looking at the problem from a problem perspective and not from their discipline perspective. And finally, I would say, I'm just tempted to say this. I mean, we have the Medical Council of India, then we have the National Medical Commission. I don't know, do we need a National Public Health Commission, or do we just need a National Health Commission which sort of breaks this boundary between medical and social? Thank you.
Thank you very much. I'll now hand it over to Rajiv. I think there are quite a few comments and questions in the chat box. Can we please take that forward?
Thank you. The comments on the chat box include some on the COVID, which is drawing upon Professor Veena Das's talk. But there are also comments on. So I'll start with the first one, and the first one relating to this panel popped up immediately when Professor Khaka gave the example of technology institutes, and the comment is that IIT is not the model. Professor Khaka, over to you.
Well,
to be fair, you said it's a beginning.
No, it's a, no one can, if in the sense that if there's a teaching of public health and and you want to introduce social sciences, I think it is important at the medical college, etc. Really to introduce. I feel it may be not a good model, but I think one can really think of it as to how one can really adapt it. If there is something wrong with the IIT model, well, I think it's important for us to think. But it's something, if you're really thinking of integrating what is called social sciences and let's say this whole individual behavior with which medicine really does, then I think there's a need to think about. That's what I really think.
Fair enough. I would request the participants to kindly put your questions on the chat box. So I'll go to the next one, which suggests, should fora like this insist and educate the government to include local social and health rights workers in discussions and decision-making process of public health policy making? Over to any of the panelists who would like to take this up.
Yes. I mean, who can educate the educated? You see, the government thinks that they know everything. You see, and you see the academics, they think they know everything. So how to bring these two parties together is a very complex thing. I mentioned in my remarks that, even the outcome of research, when we try that this should be now in the policy, it becomes a very difficult thing to bring it to the policy, because policy is within the domain of the politicians or the government. And academics, they somehow avoid talking about politics or political science or policy. They think that we have done the research or we have given this theory, it is somebody else now to implement it or act on it. So there is no way that these two worlds, academic and this government come together. Unless there is a big public opinion, you see, from the ground level, which goes and then the government listen, because they have to come to the people after every 5 years. This is a time when they listen to the people. So these issues, which we say social issues, political issues, they are very important, and somehow these are avoided in discussions. So my point is that one should not avoid these tough discussions in academic institutions, in society as well.
Thank you. Professor Dr. Tarun Bhatnagar, the two comments I'll read sort of link to where you ended. And the first of this is, in medicine, it's the individual who approaches doctor for treatment. In public health, population is at the center. Health promotion, social determinants, understanding intersectionality has created the space for social scientists to add value. For all of these, we need to bring social science closer to public health and making it multidisciplinary. And the linked comment perhaps is where you ended in a sense. Perhaps a window will open if health and not illness is made the basis for both fields. Dr. Bhatnagar.
Yeah, I guess that's what we need to be aiming for. But we need to find, as I think Professor Rama asked the question, which is the forum? Where do we do all this? So, I mean, since somebody mentioned about patients coming to doctors, I'm also thinking about places, I'm just thinking more globally, where along in the hospitals, apart from the doctors, you have, say, social workers, you have behavioral professionals who work along with the doctor to actually understand the problem of the patient. So I guess there are models available to look to see how we bring this together into the medicine side of things, these avenues to do that. I'm also thinking of, I'm just more recently with the National Health Mission. Now we have a lot of non-medical professionals who are actually working in the public health departments. You have economists, you have some social scientists, you have other disciplines, veterinarians, and other non-medical people who are looking after. You have people working in environment and so forth. At least there's some scope at this point of time for this some voices from the non-medical scenario to be heard, and they are playing some role. But yes, I guess this has to be mushroomed into a much bigger action-oriented thing than what we are seeing right now.
Thank you. Dr. Professor Veena Das has very kindly put in the comment box that she's here to address a few questions. So we will bring this to an end with another couple of questions. The next one, which are sort of stringed questions, if I may, a set of three. So it asks, why do the community medicine and public health faculty and disciplines in India not be required to imbibe the advances in the discipline and essentiality for medical specialties, given that social and ecosocial epidemiology are now well established for over 20 to 30 years? And why do the faculty not adopt and teach these along with what is the basic conventional curriculum? And then the curriculum will change over time, etc. I think the fittest person to address this is Dr. Rajesh Kumar, with your lifetime experience in both community medicine and public health departments. Over to Dr. Rajesh Kumar, and then we'll take up a few of the COVID questions.
Yeah, I think this comment about social epidemiology, has developed and is developing further. but you need a good background, good understanding of sociology, social sciences to do that. It is not enough that you understand a little bit of it and then start practicing it or start using it. So for that, you see, we have to create academic positions in the School of Public Health for social scientists. There has to be a multidisciplinary faculty. And for that, we have to accord equal status to all the disciplines. I mean, sadly, there is this hierarchy between disciplines. You see, medical science as a whole, we place this IIT, so-called medical colleges, at a very top hierarchy, and rest of the disciplines, you see, are placed lower down. So first, this understanding that, every discipline is important and contributes. And
Rajesh Kumar, sorry, there's a linked comment, and I would request you to take this into account and then close this. So
yes,
one of our participants writes that I respectfully beg to differ that the burden of public health is mostly on medical doctors. Health economists, health environmentalists, epidemiologists, etc., playing just as important roles. So
yes,
factoring it in.
yes, of course, when people become ill, they will come to the doctors. But the origin of illness lies in our social system, you see. So the social system is what is creating illness, generating illness. So our burden will never reduce, you see, unless we pay attention to that part, you see. So from that point of view also, we have to build collaboration and alliance with social sciences and understand social system, political system, economic system, and see what are the problems over there and how those problems can be taken care of eventually, slowly, and disease burden reduces. So my response is that it requires collaboration. Thank you.
Thank you. Professor Veena Das, can we get you back on the screen? Thank you very much for being there to take up a few questions. So one of the questions is, and I read, one of the key issues is not just about the lack of data, but the way that different sciences or disciplines are hierarchically arranged. And the issue is about the hierarchy oblique power. So how are we trying to overcome this in the COVID context? Professor Veena Das, please.
Yeah, I mean, I have to confess to some despair at this hierarchy between data and theory. So when one says it's not just data, it's as if data is dispensable to theory. And my major issue has been that why is it that knowing that India has the highest number of TB patients, there was no attention given to comorbidity when these epi models were designed and when policy was designed as to how it is that a policy of lockdown and of converting so many hospitals into COVID hospitals is going to have an impact on the TB patients who depend upon these for regularly accessing medicines. So that's one. The other is, it's part of the disregard that to me, it is astonishing that till 2012, TB was not a notifiable disease in India. And that when arenomyopathy and so on began to look at it, you know what the numbers are, which is on the basis of pharmaceutical sales. They concluded that 1.19 to 5.34 million tuberculosis cases were treated in the private sector in 2014 alone, right? Which means that if we just take the middle point, it's 2.2 million cases of TB, which is being treated in private sector, right? And, this sense, therefore, that we can talk in general very often about, We're very concerned about hierarchy of disciplines. We're very concerned with it, and all those are important. But I think much more important is that if we sit down and say, what is it that we really need in order to be able to actually attend to these problems? I actually just see, see such a dismal record in some ways. Even this migration that happened, I mean, really a 2-day delay in declaring the lockdown and looking at a random survey of saying how is it going to have an impact upon those who are dependent upon daily wages and who don't have the reserves to be able to actually face a lockdown. They won't have the food. They will be locked up in small little rooms. How is that going to have an impact? The second is, I totally agree with the comment that was made, which is that when we assume that, that it's the doctors who carry the major burden of public health. I mean, my point in really bringing the question of street bureaucrats to the fore was that who disappears from that? The nurses disappear from this, the health aides disappear from this, the Anganwadi workers disappear from this, the Asha workers disappear from this, but they are the people who are carrying, in some ways, very major burdens of public health. So during COVID-19, if you think about the fact that in the first 3 months, the Anganwadi workers who were recruited then to go and do these household surveys were given no protective equipment, right? And it just it makes my heart break to see that in some ways we have such a casual way of thinking about data. We have all the right concepts, we have all the right theories, and we really bemoan the fact that the government doesn't listen, but we actually don't generate the data. So one of the TB experts told me, he said, I know that what we publish is totally, has many gaps. He said, I know what I publish has many gaps. I would love to wait for writing a better paper, but TB will disappear from everybody's mind if we don't keep on talking about it, right? And so I think that's the kind of situation that it seems to me that the definition of, what is COVID-19 itself, and I think some people did raise questions about, and it's not so much a question of epistemology, but the ontology of disease. And if we begin to think about the ontology of disease, then in a certain sense, the fact that diseases come in clusters, in the Indian case for the poor, is one of the most significant facts that needs to be addressed. I'll say one more thing over here, which is that there is a very quick sort of sense in which one assumes that, that the question as to who advised for total lockdown is a very good question, because people were...
Professor Veena, if I may interrupt you, because there is a linked probe. I mean, I'm not probing it from one of the participants, and it asks, is it only a question of bridging the gaps that exist in bringing social sciences into epidemiology, or the very way epidemiology caters to the interests of policy?
I'm not into, so I think I know that everybody loves to think that criticism is really about being, slashing somebody and saying it's because epidemiology as a whole caters to policy makers. I don't think that serves very much. The geography of blame is not what is at issue over here. It's a blindness to what is before our eyes. That seems to me is what the issue is. And so, which is why I brought in the fact, we talk about doctors carrying the burden of public health. But what about the nurses? What about the Anganwadi workers? What about the, Asha workers? Why are they not figuring primarily as the people who should be at the center of attention when we think about public health? The other, related question over here is the one that, I'm sorry, I lost a little bit of my stream of thought there. But this whole question really of who advised for lockdown to happen. And I do want to point out that there were alternatives being discussed. Pakistan, for example, and Punjab, for instance, for a while had smart lockdowns, which means that they were doing, they were saying, okay, 1 week lockdown over here, right? Because we've not heard of any cases. And it's a difficult thing because after all, COVID could be symptomless, right? And there could be COVID cases in the population about which we know nothing. But they followed a smart lockdown, which meant that there were periods when people could go out, they could go for their job. They couldn't go every day for their job, but they could, they could bring work home, right? So there were alternatives which were available, and these alternatives were not taken, partly, I think, because of this whole idea that it was too risky to really trust the fact that we would have to be making decisions, so to say, which would have to be flexible rather than one model that is available and which can be fit over there. These are very, very serious questions in one way, which are not solved by general discussions about what should be the place of social sciences, quantitative versus qualitative. I work with a group of interdisciplinary colleagues, which ranges from clinicians to economists to operation research people. And I have to say that the interdisciplinary projects come through when there is a real problem that you're facing, right? It's like, when you controversies die out in some ways when you have to say, all right, we're getting these numbers, but what do these numbers mean? You really begin to see a real conversation that is happening. So, that's the reason why it seems to me that the conversation cannot just be that, we create for ourselves new professorships and we create for ourselves new committees and we create for ourselves new commissions. I think it has to be, what are the problems that we're trying to solve? The last point I want to make is that if you look at the COVID-19 period, look at the number of papers which had to be retracted, including the ones which the ICMR strongly advocated, which was the use of hydrochloroquine. And it was very clear that when WHO withdrew their trial on this, and there were objections from the ICMR, that in fact, the data on which this had been put was very thin data. In one case, in fact, a particular paper, I won't name I will not name it, actually took experiments which were done on mice in Switzerland and assumed that these could be simply passed on, projected onto the humans. So clearly, this was also a period of tremendous kind of opportunistic kinds of ways in which people, put forward very unfinished theories, not to speak about all that immunity kit projected by Patanjali, on which legal cases are still going on. And we need to really identify what the problems are that we need to be addressing in more concrete terms, it seems to me. And that will be seen as anti-theory or anti-conceptual. But this is the point I would just want to make, that instead of a geography of blame over here, it would be really good to identify what the issues are, why it is that we have never had proper estimates of people being treated for TB in the private sector. Why is it that we don't actually see that the private-public partnership emerged out of necessity, not out of ideology? And what exactly might happen if we begin to take this as the specificities of the questions? And as I said, what kind of data should we have? The fact that we don't have any data on what are the average number of contacts that people in different kinds of social groups actually have means that we actually cannot make better epi models because we just don't have the data. So that's that's my take on some of the questions that have been raised. And I'm sorry if I appear a bit sharper than I intend to, but it's been very heartbreaking to work on, on the way that tuberculosis, even in 2 cities that we've been working on, resurfaced during COVID-19 and disappeared from public consciousness, so to say. Thank you.
Thank you. And we have been able to stick to the time schedule that we had planned for. So we bring the question and answer session to a close and hand it over to the chair for his concluding comments. Dr. Murekar, please.
Thank you, Dr. Rajiv. I also want to thank all the panelists as well as Dr. Rama for a very interesting discussion. So I want to give basically two comments. One about on the talk of Dr. Veena about reflections on COVID. I agree with her. This is certainly, there's no point blaming anybody. COVID was a lifetime pandemic, and several lessons could be learned from the COVID-19 experience. And unless we learn from this lesson, we are again going to land up in the same situation. Some of the important, and there have been several exercises in India to learn from, to draw what are the important lessons, and several actions have been taken based on these lessons. But couple of points I feel worth mentioning, which I agree with Dr. Das about regularly collecting data about contact pattern. I think that certainly needs to be taken. Ensuring continuum of care, not only for TB, but also for other chronic diseases like hypertension, diabetes, or cancer treatment. This is very important. And in the case of crisis, one need to take care of these issues also. I also feel that during COVID-19, I mean, in situations such as COVID-19, I mean, having a social scientist in a control or command control room is also important. So that also is one lesson I think we can draw. The second point I want to talk about the engagement of epidemiology and social science, and this is a very important issue. I know because few years back I attended a symposium where there was a discussion as to how to better teach community medicine. And this question really is not asked as to how to better teach medicine or surgery. So we, as a public health persons as well as social scientists, really need to reflect as to how these disciplines are could be taught in better way. In the panel discussion, we learned that there has been a collaboration which has been growing in recent years, but there are a lot of gaps when it comes to the engagement of epidemiologists as well as social sciences. And primarily because both of them work in silos and in very few places and very few institutes, there is integration, there is collaboration between these two disciplines. And this is particularly important because in India, there are more than 100 MPH programs currently ongoing. And unless some action is taken at this stage, the graduates may not be really having all the skills of both epidemiology as well as social science. So, and one important suggestion that was given, I really like that, is epidemiologists could be a change agent if they get trained themselves in social sciences. And that could be a model which could be worked in some of the schools of public health. And I also want to tell about our experience of collaboration with Dr. Rama, Dr. Rajiv, and their team. As Dr. Tarun mentioned earlier, our social science or social and behavioral science curriculum was very heavy on theory. And people really, especially those who are medical officers or the primary trainees for our course, were really not interested in understanding the theories of social science. But for the last, I think, 6-7 years after this collaboration, we really are finding a change in the students. They are willing to undertake their dissertation projects, not only covering the biomedical part of a problem, but also the social problem. So I think that could be one model. But I really feel that there has to be a drastic step taken to make these courses as interdisciplinary courses. We need to relook at the curriculum and the way social sciences is taught in this public health program. I think I will close here. This is already 7:30. So over to you, Dr. Rajiv, for any further comments.
Thank you very much, Dr. Mureka. Once again, on behalf of the organizing team, we express our gratitude to the panelists and the participants. And I end with a final announcement of the next two webinars, which is on your screen. The next one is scheduled on 16th of August, the Politics of Knowledge and Integrative Health Systems. And the one after that on 30th of August, Paradigms in Health Systems Research and Policy Studies. The details will be emailed in due course. And once again, thank you very much. Good night and closing this.
Thank you very much.
Thank you. Thank you so much.
Thank you.
Thank you.